Good evening, one and all. On behalf of AstraZeneca, I extend a warm invite to for those who have joined today for this virtual event on the recent advances on hepatobiliary cancers. And I extend a special invite to Dr. Rimasa, who has joined from Italy for today's discussion. And without much delay, I welcome Dr. Sanju sir, who has extensive experience in managing diverse oncology over a decade and with special focus on GA cancers. Looking forward to your insightful discussion, sir. Please, I request to take over the session for today. Yeah.
Thank you, Sridevi. Welcome, Dr. Lorenza Rimasa. So today's session is very crucial for our daily practice, basically because hepatobiliary cancers, they are one of the most toughest cancers to deal with in daily practice. Blame it on the advanced stage at presentation or the limited treatment options. But we know that there are a lot of things happening in this particular field, and it's often difficult to keep pace with the developments, whatever happening across the world. So today's session, I'm sure that we are going to get enlightened over various issues we face in our clinic, and I'm sure that end of the this 2 hour session, we are going to get enlightened about what to do next for our patients who is going to come to our clinic tomorrow. Today, we are fortunate to have an international speaker, Dr. Lorenza Rimasa. She is Associate Professor of Medical Oncology at Humanitas University and Head of Hepatopancreatobiliary Oncology at IRCCS Humanitas Research Hospital in Rossano, Italy. She is Head of External Relations and member of Executive Committee of International Liver Cancer Association, Chair of URTC HPB NET Tumors Task Force, holds the position of Special Expert International Trials Europe on HPE Task Force of the NCI and member of Management Committee of Coast Action CA22125 Precision BTC Network. She's an author of ESMO guideline on HCC and BTC. That's a very good news for us. A member of the Italian Inter-Society Guideline Writing Committee on HCC of ESMO, ASCO, ESEL, ILC, and AIOM. She is PI and member of various phase 1 to 3 clinical translation trials of new drugs for HCC and BTC. The speaker, chair, discussion, and member of organizing and scientific committee and at various national and international congresses. She has authored more than 200 articles relevant to GI cancer treatments and biomarkers, and is co-editor and associate editor, editor-in-chief of various journals and editorial board member of several journals, including JHEB, Liver International, Therapeutic Advances in Medical Oncology, Journal of Hepatocellular Carcinoma. That's a big list of achievements. Thank you so much, Dr. Rimasa, for joining us. Today's session, we'll have first a session on the clinical importance of long-term survival of advanced BTC. Dr. Saurabh will be delivering a lecture on that. As you all know, it's very important that we find more treatment options for this difficult to treat cancer. And thereafter, Dr. Lorenza Rimasa will be delivering a talk on immunotherapy as a new paradigm shift in the management of advanced HCC. Then we will have two case-based panel discussion where my colleagues, Dr. Unni, Dr. Dilip, Dr. Ashwin, Dr. Shaufiz, Dr. Arun Warrior, Dr. Nikhil, Dr. Jaishankar, Dr. Unnikrishnan will be joining. One will be on BTC and other will be on HCC. And then we'll have the closing remarks. So over to you, Dr. Saurabh, to start the first talk on the clinical importance of long-term survival in advanced BTC.
Thank you, Sanju. Thanks a lot. So I'll just share my screen. Good evening, everybody. So we'll start with a very something which has not been associated with BTC for a long time. That is long-term survival. It has been many times considered at one point as a misnomer and oxymoron, BTC and a long-term survival. because we know even patients who undergo surgery many a times have a higher recurrence rate, and BTCs are generally not something which you associate a long-term survival with, especially given in advanced stages. So here we will delve into three things. One is the first-line BTC management. What is the benefit that been with immunotherapy, and what about the real-world evidences? So the first thing to remember is by the trial by Vele, which in 2009, 2010, we got the first line treatment beyond gemcitabine. That was a combination of gemcitabine with cisplatin, and with this trial, gemcitabine cis became the frontline agents and the first line of treatment option for BTC. So this was a landmark trial with a very clear difference in survivals between the gemcitabine alone versus the gemcis combination. After this, as far as the Indian this thing goes, two major trials came up. One was a later trial. Actually, this is shown in the initial this thing, but this came on much later, and this trial came later. This was a trial by Anant and Vikas at TMH, where they compared Gemcis versus Gem-Oxali in gallbladder cancers, not the entire BTC, but in gallbladder cancers, and showed similar outcomes. And the more longer trial, which was published by Dr. Atul from All India Institute in Delhi, where again he used Gemox as a first-line chemo for advanced GBC. The AIMS trial had a very specific Gemox, which is a modified protocol, where they used oxali 80 mg on day 1 and day 8, with gemcitabine being given at 900 mg on day 1 and day 8. This was compared to the slightly modified Gemcis protocol of 1000 mg day 1, day 8, and cisplatin at 25 mg day 1 and day 8. And both were given for 8 cycles. Actually, to an extent, numerically, the Gemox arm had a slightly better, but none of which was clinically, statistically significant. But it showed that there is no difference in survival between the two arms. So both these trials were the two things, at least in an Indian context, these two became a major thing for use against Gemcis, especially in patients where cisplatin might have been difficult to give, or there were other factors which were associated with the administration of Gemcis. In addition to this, there was the trial from Mitesh Bharat and et al. That was the triplet agents, that is Gemcis and nab-paclitaxel, as compared to Gemcis alone in advanced BTCs. However, the trial was a negative trial in the sense that the SWOG 1815, that is a trial by Mitesh and others, which showed that there is no statistically significant improvement in median OS between the two protocols. So from that time, we had different types of chemo, and today's, this is a slightly different NCCN, but even today, the NCCN, as far as it's concerned for advanced biliary tract cancers, the preferred regimen as of today is gemcitabine cisplatin with durvalumab. In an Indian context, one can also substitute oxali for cisplatin, and which is given as other recommended regimens under NCCN. So we have at least gem and a platinum with Durva or Pembro as the first line options as of today. From around 2023, 24, 25, all of these things we have had this regimen. So the first study was a Korean and Korean UK study, again by Vele and Du and O. This was the Topaz one, where they give placebo versus durvalumab in combination with Gemcis, and both were given up to 8 cycles. It was a 1:1 randomization followed by Durva maintenance until progressive disease. Now, these studies, one of the important things, at least from an Asian point of view, had a good number of Asian patients. I think it was a given because we had an Asian as one of the primary trial person, the first author of the trial. And the others were relatively good numbers were there. That is the Caucasian and the African American and other populations. So there were varying stratification factors. These include disease status and the primary tumor, whether it's intrahepatic or extrahepatic or a gallbladder cancer. And there was also different types of MSI, but the number with MSI high was a bit lower. There were only 3 patients at durvalumab arm, and placebo had only 2 patients with MSI high. Irrespective, the 3-year OS data from Topaz 1 showed a good survival benefit from the triplet arm. Here, the triplet arm being addition of durvalumab to Gemcis, as compared to the placebo with Gemsys. The 36-month also led to a very good improvement in overall survival. Now, but if one takes into the forest plot and sees the tap more than 1%, that is with the respect to the PDL1 expression, there's a definitive good amount of advantages with the values coming well onto the left side of the curve. However, once we go to the PDL1 negative or low, you do realize that the lines do straddle the midline, but the numbers are also low and the confidence interval is very long. So the benefit is not as high as a TAP1, but still it is there, but the numbers are not very high. Second point is in recurrent diseases. Again, if one sees the plot, one sees the numbers are not very high, and the graph straddles the unity line much higher way. But still, irrespective of these two, how to put it off slightly discordant notes, the trial was overall a very good success and had a very good benefit across all spectrum. Progression-free survival also showing an extremely good outcomes. The ORR ratios also had excellent across the board, whether or not the PDL1 was elevated or not, you had excellent responses. And if one stratifies according to the different protocols, how many were CR, PR, with Durva, with placebo and others, again, overall, there was an yearly clear and separate curves in entire study, showing a definitive benefit with durvalumab. So coming to the next action, which we all know by the time, but at that time, durvalumab, some of the adverse events were still being worked out. But again, the total number of adverse, in the sense of a serious adverse event, that is anything about 3 or more, were relatively same in both the arms, and immunomediated events were not very high in the durvalumab arm. So in general, durvalumab, after this addition to Gemsys, was overall established as a standard treatment after Topaz-1, and this is one of the major factors which led to durvalumab's approval in this disease field. Second thing was the further workup on this. That was what about the mutation status in the patients who had responded in Topaz-1. So genomic alteration was extensive. The study was done, and to know what were the different genomic alterations. The TP53 had a pretty high prevalence. The others also had a lot of relatively lesser, but certainly significant prevalence. Some of the common ones were TP53, CDKN, KRAS, SMAD4, and IDH1. So the rest of it was also there, including ERBB2 amplification and other factors. But predominant common ones were TP53, CDKN2A, SMAD4, and IDH1, and KRAS. So what about the genomic alteration and survival data? So ERBB2 amplification, if it was wild type, there was definitely a role for what you call the durvalumab, but with an alteration in ERBB2, this is something like what we have in other situations also. The chemo arm had a definitive advantage. Again, one more thing which I would like to point out, IDH1 mutation is somewhat similar, but the numbers are very small, with slightly favoring the durvalumab arm in IDH1 mutation. But despite that, the overall thing still remained the same. The only other mutation which had a negative impact on the use of durvalumab was ARIDA1A, which again favored the chemo. So the two common things which had a effect on this is the ERBB2 amplification and ARIDA1A. Probably maybe we should be checking at least ERBB2 amplification before deciding whether to give Durva or not, at least based on the original Topaz trial here. We have other agents which have come along, which can be used in this situation. Now, in addition, we should not forget, although this is a Durva, the study from the other side, we also have pembrolizumab, which has been approved as the other first-line agent in advanced BTCs. Now, interestingly, the other factor which is sometimes used, and sometimes which I use many times, is I think many of us are using it, is continuation of gemcitabine along with the immuno agents, and many patients do end up tolerating it. And this has its own benefit, continuing it till progression or intolerable side effects. So the study from the KN966 also showed a benefit for a maintenance treatment. And this has remained a very good factor. I think in all patients with a reasonable PS, one can consider add-on to gemcitabine with maintenance for this. So, in Indian studies published in SAGC by Manish and DC Dawal sir has shown again the maintenance gemcitabine had a good role. Again, this study began prior to the durvalumab or the immuno-oncology days. So, in a present day situation, combining it might be a good option here in patients, as I said before, who had a good performance status. Now, what about continuation of chemotherapy? Again, there was another trial from TMH. However, the TMH trial was not so positive on the maintenance chemo arm. The Vikas study from the study by Vikas from TMH, they showed that the OS was lesser than the other studies which were shown. And probably there was a subset of patients who might be benefiting, but others were not benefiting from continuing in terms of survival factors. So a palliative option of continuing was not supported by this study. But irrespective of that, there were other studies which supported it. I think a good PS patient, one can consider combination as continuation. However, as far as immuno-oncology remains, there are not much of a doubts about it. Durvalumab remains a good agent, and immuno-oncology maintenance is a very well-established agent as of now for advanced BTC. One more thing I would like to point out is the in the real world data. One is the durvalumab gemcitabine cisplatin advanced biliary tract cancers, which was an exploratory analysis of all the real world data. Again, the number of tumors where all of them were there, but intrahepatic being more common. Again, as it happens in most of our situations also, gallbladder was only 22. Most a smaller proportion of patients, nearly 30%, 1/3 only had previous surgery, and the liver functions were normal in 37% of patients and were not known in the other group. Again, they showed a similarity. This analysis actually showed a similarity to the TOPAZ-1 trial, and with a good separation of curves and overall survival data. The Italian study also came along. They also did a real world evidence update, again showed the similar benefit with the studies. So the final thing which I would like to make one more point around is the adding durvalumab also increases the OR. This is seen from the TOPAZ-1. Also in the real world data analysis also has shown the same data as was shown in the TOPAZ-1 trial, that adding durvalumab increases the ORR rate. Finally, we had a study by Vamshi and Vikas from different and other parts of India, including a huge number of people, which showed that the real world data of adding gemcitabine with cisplatin and durvalumab in advanced BTC, multiple centers all across India, although from southern India, other than Telangana, there was only Tamil Nadu center which had a few patients which was contributed. However, of a 145 patients included, because a number of patients from northern and northeastern India, there was a good proportion, higher proportion of GB malignancies which were patent, but also patients had a slightly poorer PS than the other study, where which was 0 to 1, we had patients up to 2 or even higher sometimes being present there. Here also but the data showed a consistent survival benefit as similar to that of TOPAZ-1. And since this was an extremely heterogeneous data from the northeast of our country to the different parts of India, they still had a similar survival curves as that was there in the TOPAZ-1. The adverse events were still smaller, and grade 3 or 4 toxicities were only in 7.4% of the patients. So from all of these, what came out was that the real world experience are similar to that in the phase 3 TOPAZ-1 trial. And there are no new safety signals even in the real world data. And poorer performance status patients also tolerate addition of durvalumab. Now, the final thing, more importantly, I think, especially from certain parts of India, where GB cancer is much more common, the addition of durvalumab seems to benefit those set of patients also. So in summary, I would like to say that TOPAZ-1 and K966 were the trials which established IO plus GemCis as first-line management of an advanced BTC. And addition of IO to GemCis does not worsen the toxicity, and the toxicity side effects remain more or less comparable. And durvalumab, with certain exceptions, as we discussed in the prior slides, is across the board, irrespective of genomic alterations, seems to do well. And the one Indian study which has looked into the real world evidence seems to support the studies from the TOPAZ also. Thank you. Thank you all.
Thank you, Saurabh, for that lucid presentation. So from this, it is very clear that, immunotherapy has come out of age in this particular field, and we do see patients surviving beyond that 1 year, 2 year landmark. That was quite impossible, say, a couple of years back. So we are all seeing people surviving beyond 1 or 2 years. I think the data is something like 2 year survival of about 25%. So that was a very good presentation. So let's move on to the next presentation. Dr. Rimasa will be presenting on the role of immunotherapy as a new paradigm shift in the management of advanced HCCs. Over to you, Dr. Rimasa.
Hello. First, thank you for the kind invitation, and thank you for the very, very nice introduction. So I'm sharing my slides. Okay. So as you said, I will be talking about immunotherapy as a new paradigm shift in the management of patients with advanced HCC. These are my disclosures, and this is my outline. Immunotherapy phase 3 trials for advanced HCC, then the mechanism of action of anti-CTLA-4 plus anti-PD-1. In more details, the Himalaya study, the phase 3 Himalaya study with a 5-year overall survival and some exploratory analysis, and then some clinical challenges that we face every day in the clinic, guidelines and multidisciplinary approach. And before coming to the conclusions, I will present a clinical case from the Himalaya study. You all know this is the BCLC staging system. It's one of the staging systems used worldwide, even if not in all the countries. And for patients with advanced stage disease or intermediate stage progressing on or unsuitable for local regional therapies, the treatment of choice is represented by systemic therapy. And we have 2 immunotherapy combinations, actually now 3 in the guidelines, but approved in most of the countries, 2 combinations of atezolizumab plus bevacizumab and durvalumab plus tremelimumab according to the STRIDE regimen. And we also have now at least approved by the FDA and EMA, the combination of nivolumab plus ipilimumab. For patients who are unsuitable for immunotherapy, we still have the tyrosine kinase inhibitors that are the treatment of choice also in countries where immunotherapy is not available. So starting from the IMbrain 150, you all know that this trial tested the combination of atezolizumab plus bevacizumab, so immunotherapy plus anti-angiogenic, versus sorafenib in a broad population, including also patients with main portal vein thrombosis. The trial is positive. In the slide, you can see the updated results published in 2022. And there is a clear benefit in all the efficacy endpoints. With a median overall survival of 19 months, a benefit in overall survival, progression-free survival, and response rate, with a response rate of 30% with a long duration of response. In terms of safety, the combination is quite well tolerated. In the graph in the top left of the slide, you can see that the most frequently observed adverse event is a hypertension, but of grade 3-4 only in 15% of the patients. What was really worrisome was the bleeding or the risk of bleeding associated with bevacizumab. And if you look at the graph on the right, you can see the adverse events of special interest. And in the bottom part of the graph, the adverse events of special interest are associated with bevacizumab. All the patients had to receive an upper endoscopy before starting treatment. And if varices, esophageal varices, were observed, the varices should have been treated before starting treatment with bevacizumab. And this is the same in clinical practice. And with this, with the upper endoscopy and the treatment of varices, the grade 3-4 bleeding events occurred with a similar incidence in the sorafenib and in the atezolizumab plus bevacizumab arm, approximately 6%. But the upper endoscopy should be mandatory also in clinical practice. In the cursor on the bottom left in the slide, you can see the quality of life analysis, and you can see that the time to deterioration in quality of life is much longer with atezolizumab plus bevacizumab compared to sorafenib. So we have a benefit in efficacy, a good safety profile, and a benefit in quality of life. And several exploratory analyses have been presented or published and confirm the benefit of the combination in all subgroups of patients analyzed. Then I mentioned the most recently published trial, the CheckMate 90W, that tested the combination of nivolumab plus ipilimumab. This trial is a little bit different compared to the others, and also compared to the Himalaya trial that I will present in more details, because the control arm is represented by lenvatinib or sorafenib according to investigator's choice, and 85% of the patients in the control arm receive lenvatinib. So this trial is mostly versus lenvatinib and not versus sorafenib, like IMbrave 150 and Himalaya. In this trial, patients with a main portal vein thrombosis, VP4, were not included. In the curves on the top right of the slide, you can see the overall survival. There is a clear benefit in overall survival, but what is very clear is that there is a crossing of the curves approximately at 12 months. So in the first part of the curves, there is greater benefit from lenvatinib, let's say tyrosine kinase inhibitor, compared to nivolumab plus ipilimumab, or there is a higher number of deaths related to nivolumab plus ipilimumab. In the published paper in The Lancet, the authors commented this, saying that most of the deaths observed in the first part of the curves in the first months were not associated to the treatment. So it seems that they are not treatment related. That this is kind of difficult to understand, and probably we will have more explanation with exploratory analysis in the future. The publication in The Lancet is the trial was published in The Lancet a few months ago. There is no benefit in progression-free survival, and I will come back to the progression-free survival when I will be talking about the Himalaya trial. There is a benefit in objective response, you can see on the bottom right of the slide, with also a long duration of response. What is maybe unexpected is that there is a benefit in post-progression, progression-free survival on the next slide. So post-progression, progression-free survival, PFS2. So not in the progression-free survival, but in the progression-free survival on next line therapy. This can be associated with a change in the tumor immune microenvironment related to the treatment with nivolumab plus ipilimumab. On the bottom left, you can see that there is a correlation between objective response and survival. And this is something different compared to what we will be seeing in a while in the Himalaya trial, because here the patients who really benefit are the patients who have objective response. And I will come back to this in a while. In terms of safety, the percentage of patients who required high dose of steroids to manage the immune-mediated adverse events is 29%. That's quite high for patients with HCC and cirrhosis, but overall, the adverse events were manageable. And in terms of quality of life, the time to deterioration in quality of life was longer with nivolumab plus ipilimumab compared to lenvatinib or sorafenib. And also in the graph in the bottom right of the slide, this graph represents how patients are reported to be bothered by adverse events associated with the treatment. And it's clear that patients treated with nivolumab plus ipilimumab reported significantly less bother due to side effects compared to lenvatinib or sorafenib. So this is another observation that immunotherapy is better tolerated compared to tyrosine kinase inhibitors. There are other phase 3 trials with conflicting results. I will not go into the details of this, because I will go now into the details of the Himalaya trial. So first, the STRIDE regimen. You know that in the Himalaya trial, the STRIDE regimen was tested, and this is a completely new regimen with a single priming dose of 3 milligram anti-CTLA-4 and followed by durvalumab anti-PD-L1. And here you can see a cartoon with the mechanism of action of this new type of combination. You can see on the left here what happens in the lymph node. Tremelimumab, the anti-CTLA-4, has its activity here. And the single dose of tremelimumab, the single priming dose, blocks CTLA-4, and this increases T cell activation and diversity. And then upon activation, T cells differentiate into memory T cells that help provide long-term immunity, and we will see this with the clinical results in terms of long-term survival, and also effector T cells that take direct anti-tumor action. So we have a direct anti-tumor action and also an immune action, providing or helping to have a long-term results. Then we have what happens at the tumor site, where we have mostly the activity of durvalumab, anti-PD-L1, and the regular interval durvalumab, so the classical administration of durvalumab every 4 weeks, selectively blocks PD-L1 to help enhance and sustain anti-tumor T cell activity. So we have a kind of complementary or synergistic activity between the anti-CTLA-4 tremelimumab and anti-PD-L1 durvalumab. And this rationale, this background was confirmed in the study 22. That was the phase 1/2 trial of durvalumab plus tremelimumab that was conducted before the Himalaya trial. And in this trial, different regimens were tested: durvalumab single agent, tremelimumab single agent, the classical combination with 4 doses of anti-CTLA-4, 4 doses of tremelimumab at 75 milligrams, and the new regimen, the STRIDE regimen, that was not called STRIDE at that time, but with a single priming dose of tremelimumab 300 milligrams. And as you can see on the left, the STRIDE regimen showed the highest efficacy compared to the other arms in terms of survival and also response rate that is not shown in the slide, and with a reduced toxicity. And on the right, you can see the translational analysis, the biomarker analysis at day 15, and the single dose priming with the tremelimumab 300 milligrams led to an expansion of unique T cell clones and increased T cell proliferation associated with a longer survival and clinical response. So you can see here the graph of the activity, or the highest activity induced by the STRIDE regimen. And so now the Himalaya. The Himalaya phase 3 trial compared the STRIDE regimen versus sorafenib, and also included a single arm of durvalumab that was tested for non-inferiority versus sorafenib. As in the CheckMate 90W, patients with a main portal vein thrombosis were not included. Patients with the other types of portal vein thrombosis were included. Only patients with the VP4 were not included. The trial is positive. The overall survival is longer with the STRIDE compared to sorafenib. There is no benefit in progression-free survival as in the CheckMate 90W, so probably progression-free survival is not a good endpoint for the combination of 2 immune checkpoint inhibitors for HCC, and then I will try to give you an explanation of this. There is a benefit in response rate that is 20% without anti-androgenics, with a long duration of response up to 22 months. In terms of safety, the combination is very well tolerated, and this is probably related to the single dose of anti-CTLA-4 that is administered only for the first cycle. And the percentage of patients who required high dose of steroids to manage the immune-mediated adverse events is 20%. That is lower compared to other combination of 2 immune checkpoint inhibitors. On the right, you can see the curves for the quality of life. And the median time to deterioration in quality of life is longer with immunotherapy compared to sorafenib. Now, considering the long-term benefit observed in the primary analysis, exploratory analysis have been conducted to look at the overall survival at 4 years and 5 years. Here you can see the data at 4 years. And on the left, you can see that the percentage of patients alive at 4 years are 25% in the STRIDE arm versus 15% in the sorafenib arm. If you look at the curves on the right, you can see that patients with disease control, so patients with objective response, but also patients with stable disease, benefited even more. And the percentage of patients alive at 5 years is 36%. For the CheckMate 90W, I show you the curves showing a correlation between objective response and survival. Here we have a correlation between disease control and survival. So not only the patients with objective response may have a long-term survival, but also the patients with a stable disease. And here, the most recent been published analysis, the 5-year overall survival analysis. And at 5 years, we have almost 20% of the patients alive in the STRIDE arm. You know that based on literature data, patients with advanced HCC are alive in a percentage around 5% at 5 years. Here are patients that are, of course, very well selected, enrolled in a phase 3 trial and treated with a new combination. But we have 20% of the patients alive at 5 years. And the curves on the right showed, again, the correlation between disease control and survival. And if you look at patients with disease control, at 5 years, we have a 28.7%, so almost 30% of the patients alive at 5 years. So these are unprecedented results, and at least so far, we haven't seen these results with other immunotherapy combinations. Of course, as you can see on the top left, patients with a higher rate of tumor shrinkage benefit more, so the more patients can have a long-term survival, but also, as I said, patients with a stable disease. The graph on the top right showed the change in target lesions, the survival of patients, and the need of second-line therapies upon progression. So they are not probably very clear, but they look to be when we designed them. But anyway, what is represented here is that patients in the STRIDE arm had a longer survival compared to the sorafenib arm, showed lower percentage of disease progression, and a smaller percentage of patients, a lower percentage of patients needed a second-line treatment. So more patients remained on treatment for a longer period of time. And another important results of the 5-year analysis is shown in the bottom part of the slide, and is related to the safety profile. And there were no new serious treatment-related adverse events after the primary analysis. If you look at the blue bar, you can see that at the 5-year analysis data cutoff of the primary data cutoff, the percentage of patients who had the serious adverse events are almost the same. So we don't have late adverse events. And this is important because if patients remain on treatment for a long period of time, we need to be reassured. It's good to be reassured that patients do not experience late serious treatment-related adverse events. We also look at the overall survival at 5 years by baseline liver function, and you can see on the left that patients benefited from STRIDE regardless of baseline ALB grade. So both if they had ALB grade 1 and ALB grade 2 or 3. And also on the right, you can see also that the bars showed the safety profile like in the previous slide. And the rates of treatment-related serious adverse events with STRIDE did not change from the primary analysis for patients with ALB grade 1 and ALB grade 2 or 3. So we can treat safely patients regardless of baseline liver function. Of course, all patients had Child-Pugh class A to be enrolled in the Himalaya trial. Now, here, this slide summarizes the subsequent anti-cancer therapies received by the patients. I mentioned at the beginning that there was no benefit in progression-free survival, and this was initially not very clear how it was possible to have no benefit in progression-free survival, but a benefit in overall survival. And if you look at the curves on the top left of the slide, it's clear that patients continue, or at least a percentage of patients continued the treatment beyond progression. And indeed, the time to subsequent therapy is longer compared to the progression, to the time to progression. And indeed, the progression-free survival did not fully capture the benefit of overall survival improvement with immunotherapy. So probably patients continued the treatment. This was allowed in the trial because patients who had the clinical benefit were allowed to continue the treatment beyond progression. And so the time of progression did not correlate or does not correlate with overall survival. Other exploratory analyses have been conducted and showed the benefit of the STRIDE regimen in all subgroups of patients analyzed. And I show just one slide for the Asian subgroup analysis because this analysis included also India. And there is a clear benefit from STRIDE versus sorafenib also in this analysis, both in terms of survival and objective response, and also in terms of safety. the safety analysis showed that the combination, the STRIDE regimen and also durvalumab single agent had a better safety profile compared to sorafenib, and the safety profile is consistent with the global safety analysis. So also in Asian patients, including Indian patients, we have similar results compared to the results in the overall population included in the trial. Now we have, and I didn't present them, a lot of real world data for atezolizumab plus bevacizumab, because we are using that combination. We have been using that combination for some years, but recently also real world data for STRIDE have been presented. And this is just a poster presented at ASCO GI this year by the group of David Pinato in London, UK, but this is a multi-center analysis. And what is interesting here is that also in the real world, patients who received STRIDE and had the same criteria, the same baseline characteristics as the patients enrolled in the Himalaya trial, had similar results in clinical practice. Of course, in clinical practice, some patients were treated even if outside of the eligibility criteria, if patients had worse prognostic baseline characteristics, they had a worse prognosis in the end, a worse outcome, but that was related to the baseline characteristics. Overall, the results that we have so far in clinical practice are very similar to the results of the Himalaya trial. We have some challenges in clinical practice, how to choose the first line. We don't have tissue biomarkers. We don't have serum biomarkers like we have, for instance, in other cancer types. And so our decision should be based on patient characteristics, disease characteristics, drug characteristics. I mentioned that we don't have biomarkers. This is a very comprehensive biomarker analysis for atezolizumab plus bevacizumab, and the only biomarker that we can use in clinical practice is AFP. That is not a new biomarker. And also, it is not predictive activity, it's a prognostic biomarker. And so here you have a summary of the clinical characteristics that we have to consider in clinical practice, like the risk of bleeding, the concomitant medications that can increase the risk of bleeding. This is for bevacizumab. A cardiovascular assessment should be done again for bevacizumab. Severe autoimmune disorders may represent a contraindication for immunotherapy. Previously, liver transplant is, at least so far, a contraindication for immunotherapy. This probably will be changing in the future, but now in clinical practice, it represents a contraindication. I mentioned the liver function, and I mentioned that for STRIDE, the benefit is observed regardless of baseline liver function. On the left, you can see the analysis, the overall survival analysis according to ALBI grade from the IMbrave 150, so for atezo-bev. And you can see that patients with ALBI grade 2 do not seem to benefit from atezolizumab plus bevacizumab. Of course, this is an exploratory analysis, so can be biased, but this can be something different between IMbrave 150 and the Himalaya. There was a lot of debate regarding the potential correlation between etiology and activity of immunotherapy. At the beginning, it seemed that patients with non-viral etiology did not benefit from atezolizumab plus bevacizumab. In the primary analysis of Himalaya, it seemed that patients with the HCV etiology benefited less from STRIDE. In the end, there were some biases, and after adjusting for imbalances or after rerunning the analysis or based on meta-analysis, now it's clear that there is no reason to select the treatment based on etiology. You look on the right in the slide, you can see the most recently published meta-analysis, and there is a clear benefit from immunotherapy regardless of etiology. There are some differences related to etiology, related to the background related to the mechanism of action of different etiology. For instance, for HPV, there is a clear there is a higher benefit from immunotherapy that is related to the mechanism of action of the virus in the liver. But overall, as I said, there is no reason to select the treatment based on etiology. What is now clear is that there is a correlation between immune-mediated adverse events and outcomes. So if patients have immune-mediated adverse events and these adverse events can be safely managed, it's important to continue the treatment because these patients may benefit more, of course, if this is safer for the patients. So that was the first challenge, how to select the first line. A second challenge is how to sequence in clinical practice because we don't have a phase 3 data after immunotherapy. And here you can see a summary of the factors that we all consider when we are in the clinic with patients progressing on first-line immunotherapy. We have to consider the pattern of progression. We have to consider the toxicity from the first line. We have to consider the liver function. And we have to consider the clinical conditions, the general conditions. And then based on considering all these factors, we can decide if patients may continue the immunotherapy beyond progression, if this is allowed. It depends on the rules in different countries, or if patients may switch or have to switch to a tyrosine kinase inhibitor, or if patients have maybe worsening on liver function or clinical conditions and are suitable for best supportive care. But these are the factors that we have to consider and waiting for phase 3 results in second line. And there is a third challenge that we face every day in the clinic, how to treat patients who are typically excluded from phase 3 trials, patients with not so well preserved liver function, for instance, patients with Child-Pugh liver cirrhosis, patients with a kidney failure on hemodialysis, patients, as I said, with a prior liver transplant, patients with HIV. Now they are included in clinical trials, but until a few years ago, they were excluded. So patients with different or concomitant diseases that are, and for these patients, we don't have phase 3 data. So again, we have to base our decision on our on the data that we have that are mostly coming from clinical practice and real world evidence. Now there are ongoing trials, for instance, the Sierra trial, that is a phase 3B that is testing STRIDE in patients with a Child-Pugh liver function or ECOG performance status 2 or main portal vein thrombosis. So maybe in the near future, we will have data now, the safety data has been presented at ESMO GI, but we don't have yet the efficacy data. Here you can see the ESMO guideline mentioned at the beginning, and you can see that for patients suitable for immune checkpoint inhibitors, suitable for immunotherapy, we have different combinations that we can use in first line depending on the countries. In Europe, for instance, we can have atezolizumab plus bevacizumab, durvalumab plus tremelimumab, nivolumab plus ipilimumab. In Italy, we have just the first two because nivo plus EP is not reimbursed yet. Or we have, for instance, camrelizumab rivoceranib. This has been approved in China. So it depends on the different countries. And for patients who are not suitable for immune checkpoint inhibitors, then we have lenvatinib or sorafenib, and then the other tyrosine kinase inhibitors. And in the NCCN, we have the first two immunotherapy combinations, so they will probably add the nivo-EP in the near future. It's clear that the multidisciplinary approach is key for patients with HCC. There is a clear correlation between a multidisciplinary approach and survival. So this is very important when we treat our patients in clinical practice. And now, before concluding, I will present a case from the Himalaya study. That is a case that showed that how the long-term survival can be real. This is the case of a 64-year-old lady. No family history of cancer, current smoker, 10 cigarettes per day, no alcohol, no allergies. In terms of etiology, HCV-related cirrhosis that was treated with DAAs with SVR. And at the time of the treatment in 2015, the upper endoscopy showed no varices. The patient was under surveillance for the previously treated HCV liver cirrhosis. And in November 2017, a very high AFP value was observed, 14,000. The liver function was good, Child-Pugh class A, ECOG performance status 0. The CT scan showed several lesions. So you can see the orange arrows in the peritoneum and omentum, and no lesions in the liver. So we decided for a laparoscopy to better understand what was happening. A liver lesion in segment 2 was observed, not shown at the CT scan, that was removed. And also several peritoneal nodules were confirmed. One of them was excised for histology, and histological exam showed grade 2 hepatocellular carcinoma. So we had a single lesion in the liver removed and multiple lesions in the peritoneum. So now the question was what to do. Surgery, tyrosine kinase inhibitors, immune checkpoint inhibitors in a trial because we were in 2017, or best supportive care. But the patient was in very good clinical conditions with a very good liver function. Surgery is not an option, I think, for patients with HCC and peritoneal carcinomatosis. Tyrosine kinase inhibitors was the first option in clinical practice, but we decided for immune checkpoint inhibitor in a clinical trial. We had the Himalaya trial at that time. The patient in December 2017 was randomized to the STRIDE-A, and on December 22nd, we started with the first cycle. At baseline, there was a slight increase of transaminases, AST and ALT, you can see there, and AFP increased a lot from 14,000 to 84,000. We administered the first cycle, and afterwards we observed a grade 3 increase in transaminases. You can see AST 358 and ALT 348. Bilirubin was in the normal range, and AFP dropped from 84,000 to 28,000. So now the question again is, what would you do, or what we decided to do? Stop treatment, interrupt the treatment, and wait until decrease or normalization of AST, ALT levels, discontinue immunotherapy, stop definitely the treatment, and start steroids, or interrupt immunotherapy and repeat HCD testing or other liver function testing. And we decided to interrupt the treatment, so we didn't administer the second cycle, and we asked for several liver tests, including the HCV, because the etiology was HCV, autoimmune, the test for autoimmunity, and other virological tests like for HPV or other in case of another infection. But in the end, all the tests were negative. So we concluded for immune-mediated toxicity at the liver, immune-mediated hepatitis without any clinical symptoms, and with a bilirubin that was always within normal range, and this was very reassuring. So we decided not to administer steroids. This can be debatable because it was a grade 3, so steroids could have been administered. We monitor very strictly the patient, and we observed a progressive decrease in transaminases levels. So you can see the AST and ALT from grade 3 to grade 1, 2, and to grade 1. When both the transaminases were grade 1, we decided to administer the second cycle. That was approximately 2 months after the first cycle. And with the subsequent administration, and it's important to remember here that from the second cycle, we administer only durvalumab. We don't administer any longer tremelimumab, and so the liver toxicity is mostly associated with anti-CTLA-4 more than anti-PD-L1 or PD-1. And administering the following cycles, we observed a progressive normalization of transaminases, and bilirubin was always within normal range. In April 2018, so after 4 months, we observed a partial response, and the AFP was reduced to 300. We started with 84,000, and now we have 328. And you can see one of the lesions in the peritoneum in the red circle with the that was clearly reduced in diameter. In terms of adverse events, we observed grade 2, grade 1, 2 fatigue, and grade 2 hypothyroidism. In terms of immune-mediated adverse events, hypothyroidism is the most frequent. And indeed, we started treatment with levothyroxine. The treatment was continued, very well tolerated, and after 1 year, we observed an even more partial response with AFP within normal range. So we continued the treatment, and in February 2019, so more than 1 year after treatment initiation, we observed a complete response. And this is important because with immunotherapy, we can see late responses with AFP within normal range. Then we went on with the treatment. We observed a pulmonary embolism that was completely unrelated and treated with fondaparinib, so this is not relevant. What is relevant is that we continued the treatment. We started in December 2017. You can see on the right in the slide the graph of AFP. And I will move to the conclusion here. At the latest CT scan at the end of April, the next one is planned in the next days, we confirmed the complete response. So the patient has been on treatment and is still on treatment, has been on treatment for 7.5 years. The treatment is very well tolerated, except for a grade 2, that is a grade 1, actually, fatigue, with a complete response starting from peritoneal metastasis, histologically confirmed, and with an AFP that started from 84,000 and now is within normal range. We can discuss if it is useful to go on with the treatment. We discussed with the patient multiple times. She doesn't have adverse events, and she prefers to continue. And the treatment is still on the trial, so it's not paid by the government. Now, to conclude, atezolizumab plus bevacizumab, durvalumab plus tremelimumab, and nivolumab plus ipilimumab are first-line standard of care. STRIDE provides a long-term survival benefit with a 5-year overall survival of 20% and 5-year overall survival of 28.7% in patients with disease control, objective response, or stable disease. Exploratory analysis supported the efficacy and safety of STRIDE in all subgroups of patients analyzed. Predictive biomarkers for immunotherapy are infrequently found in HCC, and there is an unclear correlation with outcomes, while there is a correlation with outcomes between immune-mediated adverse events and AFP changes over time. For the future, new immunotherapy options will further expand the treatment scenario. We will have immunotherapy single agent, novel double and triple immunotherapy combinations, the combination of local regional therapy plus immunotherapy combinations, and there are ongoing trials of immunotherapy combinations in different settings. And we do need biomarkers and clinical factors to select the optimal regimens and sequences for different groups of patients, including special populations. And I thank you so much for your kind attention.
Thank you, Dr. Rimasa, for that, excellent presentation. So we got a taste of what's happening in this particular field. Any questions from the audience? So if there are no further questions, shall we move to the case discussion? Dr. Unni will be presenting?
Yeah, I'll be presenting, sir. I am in the airport. So I'm so sorry for any disturbance happening in between. But I'll be presenting. So shall I start, sir?
Yeah, sure.
So thank you, Professor Lorenza and other colleagues for the excellent presentation. So excellent. So I'll be presenting 2 cases. One will be on cholangiocarcinoma, another will be on, one is cholangiocarcinoma, one is PDL1, one is HER2 positive, and one will be a normal routine cholangiocarcinoma, which we see. So this is a case of, I hope this is visible for everyone. Say, a 56-year-old healthy man with a cholangiocarcinoma. So what are we going to do? He's having a pretty advanced disease. I'll ask my colleague, Dr. Dilip, how will you go ahead in this situation?
So,
what all tests you will do?
Yeah, so in a metastatic intrahepatic cholangiocarcinoma, as of now, I would do, we have a targeted therapy, which is based on the IDH1, IDH2 mutations, FGFR mutations, and to an extent HER2 also, and the PDL1. So I think these are the things which we'll do. And the LFT and AFP, of course, for the test, LFT for the organ functions and AFP just to rule out any hepatocellular carcinomas.
I think it's very evident that we have got newer molecules to treat this cholangiocarcinoma, and it's not just chemotherapy alone, and we should do a proper IHC and also some of the molecular markers. Let me ask Professor Lorenza, forgive me if I am pronouncing your name wrongly.
No, it's perfect. Perfect.
What all IHC will you do in routine scenario, and what all molecular tests you will do? if it's a molecular test, will you go for a comprehensive genomic profiling, or will you happy with a limited targeted molecular test?
So we are used to do a complete comprehensive genomic profiling within NGS, with large panel NGS, like 500 genes, both DNA and RNA, because now this is reimbursed, so we are happy with that. But anyway, for clinical practice, what is really important is to have the results of IDH1 mutation, FGFR2 gene fusions, HER2 overexpression, because these are the molecular alterations for which we have targeted agents available in most of the countries. So ideally, I would say a large, a comprehensive panel, but mandatory if possible, at least the molecular alterations that are useful to select the treatment.
Thank you, ma'am. Thank you. So when we consider the treatment for this patient, I think we have many chemotherapy options. I will ask Dr. Ashwin, what will be his preferred option among all those things?
Yeah, thank you, sir. So I would look at the LFT, see if it's that all those things are okay. There's no obstructive jaundice, and if it's in the normal range, I usually go for a GemCis based regimen. Day 1, day 8 is what I usually go. If not fit, then I consider a Gem Carbo or a Gem Ox based regimen.
Okay. So let me ask Dr. Shaufis, what will he consider? Because all these options are really good options, and there is nothing much to choose between them. So,
hello. If finances are not a concern, then GemCis with the IO will be the first option.
So let me ask Professor Lorenza, what will be her chemotherapy choice in this situation?
Yeah, I would use gemcitabine, cisplatin, and immunotherapy.
So now, regarding the $1 million question, among immunotherapy question, which one you choose? I'll directly ask Dr. Lorenza, because this is a very difficult question. And whenever we read, somebody will say that pembrolizumab is good. The AstraZeneca people say that durvalumab is good. So where will you place these two molecules in this clinical scenario?
So I don't think there is a real difference between the two molecules. Actually, of course, one is anti-PD-L1 and one is anti-PD-1, but I don't think this is associated with different results. What we have to consider is that the two trials had some differences, and we have to consider that there were some slight differences in terms of baseline characteristics of the patients, and there were differences in the design of the studies. For instance, in the Keynote 966, gemcitabine, it was allowed to continue gemcitabine on 8 cycles. So the maintenance could have been represented by Pembro alone or Gem-Pembro, while in the TOPAZ-1, both chemotherapy agents were stopped at 8 cycles. And also pembrolizumab was administered for a maximum of 2 years, while in the TOPAZ-1, durvalumab was administered without a maximum duration. And we have some long-term data also for TOPAZ-1. And so maybe in some cases, the long-term administration of durvalumab can be helpful. So I think that we don't have a direct comparison. And so we can consider what, and also if you look at the forest plots, all subgroups of patients benefit in both trials. There are some slightly differences, but patients benefit. So we have to base our decision on the clinical characteristics. For instance, if we want to administer gemcitabine beyond 8 cycles in combination with immunotherapy, we should prefer Pembro. If we are confident in stopping chemotherapy after 8 cycles, for instance, we are used to stop after 8 cycles, even before immunotherapy. We were used based on the ABC02. Then we can use the TOPAZ-1 regimen. For the TOPAZ-1 regimen, we have real-world data as presented earlier today that we don't have, or at least we have less real-world data for Pembro. So also the real-world data can be helpful in guiding the decision. But it's a really difficult question because we don't have the answer.
Excellent answer, Professor. So thank you so much for your answer.
Excuse me, sir.
So now we,
One second. Sir, can
so
I just
shall
come
we?
in for a minute?
Yeah, please.
Yes, I'm Dilip. Ma'am, would you consider the ESMO MCBS scoring in this? Because ESMO MCBS has given a score of 4 for Durva and 1 for Pembro. So would you consider in choosing this?
Yeah. This is important that the score has been changed very recently, and yes, there is a higher score for durvalumab, and this is related to the more consistent results, let's say, because we have the overall survival, we have the progression-free survival, we have the response rate, while in the Keynote 960 we don't have benefit in progression-free survival and so on. That can be considered. To be honest, I consider more the patient that I have in front of me in clinical practice, and we are. I have also to say that we are very used to use durvalumab, so in most of the patients we use, and we published a lot for in terms of real world evidence. So we use durvalumab in most of the patients.
Okay, thank you.
So going to the next case. So same patient, if the patient would have been HER2 positive, how are we going to manage? What will be the first line chemotherapy Shawkis for this patient?
Gemcis with Trastuzumab.
Hello, Shawkis?
Yeah, Gemcis tablets is applied with the Trastuzumab.
Yeah. So how many of us will add the pertuzumab along with the Gemcis Trastu? Dilip, Ashwin, and Shawkis?
No, sir, I would not.
No,
add.
I wouldn't. We wouldn't add. I wouldn't add.
So as currently said, we will be giving a chemotherapy plus trastuzumab, Gemcis trastuzumab. And now I'll ask Professor Lorenza, when will you consider trastuzumab deruxtecan? Because, and the second question is, will trastuzumab deruxtecan replace chemotherapy plus trastuzumab in this scenario?
No, actually, I wouldn't use an anti-HER2 agent in first line because we don't have phase 3 data. So I would go for cisgem immuno in first line and use an anti-HER2 in second line. And to use a anti-HER2 in first line, either trastuzumab deruxtecan or zanidatamab, I would enroll the patient in clinical trial. But I wouldn't use an anti-HER2 in first line without phase 3 data.
Dilip, go ahead.
Yeah, ma'am, actually, as you told correctly, we only have a phase 2 data. But when you consider the HER2 amplification, is it a kind of a resistance mechanism to immunotherapy? Would you consider that way? Because I think in the Durva study, the Topaz study, I think they had a subcohort where the forest plot actually went towards the chemo arm alone. So that's why I asked.
Yes, it's true. The Topaz 1 trial was not powered to show differences according to the molecular alterations. That was a post-hoc analysis. So I would use immunotherapy anyway. If you don't trust that immunotherapy can be useful in patients with HER2 amplification or overexpression, then I would go for chemo alone. But I wouldn't add, at least so far, probably in the future, yes. But now I wouldn't add an anti-HER2 in first line because we don't know if it is active or not. And if we should combine or not. For instance, the ongoing phase 3 trial with the trastuzumab deruxtecan is both combining trastuzumab deruxtecan with immuno and also administering trastuzumab deruxtecan as single agent. Or in the zanidatamab trial, there is a combination with the cisgem durva or with the cisgem. So there are ongoing trials that we will see in the future. And we have to be very careful with the exploratory analysis. I presented a lot of exploratory analysis in HCC, for instance, but we have to consider them for what they are. So exploratory analysis, it's difficult to exclude patients from immunotherapy based on exploratory analysis. At least this is my opinion.
I shall hand over the podium to Dr. Sanju, and then I shall leave because I'm already inside the aircraft. Thank you. And I'm really sorry for the inconvenience for all the patients, all the people. Thank you.
धूम्रपान और इलेक्ट्रॉनिक उपकरणों या मोबाइल फोन का प्रयोग करें। बच्चे green fuel is in progress for this aircraft, and we ask you to remain seated with your seatbelt open. Smoking and using
Only please mute your phone.
Yeah, sure.
नमस्कार, अपनी यात्रा को शीघ्र शुरू करने के लिए आप अपने बड़े बैग्स को ऊपर वाले ओवरहेड रखें और छोटे बैग्स को सामने वाली सीट के नीचे रखें। कृपया अपनी सीट पर ध्यान रखें।
So Dr. Unni sir, like please mute yours.
So, Dr. Rimasa, so what you are telling is if you have a patient of HER2 positive BTC, you will consider frontline GemCis plus immune checkpoint inhibitors rather than adding HER2 directed treatment upfront, right? That's a
Yes, right.
yeah. So if you see the trials here, so the TAP study showed that this is something which I don't know whether we can neglect. So this is treatment naive biliary tract cancers. The disease control rate is as high as 80%. So this is something which, though it is a single arm multi-institutional phase 2 study, a disease control rate of 80% with about 50% of the patient responding is something which we don't generally see with even immunotherapy. So how can we, neglect this data? That was my doubt.
No, the problem is that I don't think we have to neglect this data. So I'm quite sure that anti-HER2 are active in patients with a HER2 overexpression. The problem is that multiple times we have seen positive phase 2 trials, and then the results have not been confirmed in large phase 3 trials. So we have here a disease control rate that is really impressive, 80%, as you mentioned. But for instance, the median overall survival is not so impressive. Of course, probably these patients have a worse prognosis, so that can be the case. And also there are only 90 patients. So I think these data are, let's say, promising, but I would like to see larger phase 3 trials. This is my opinion.
Okay.
So is it because you will find it difficult to get a phase 3 study with so many number of patients to prove superiority? That will be the biggest challenge. Isn't that the thing that is going to be difficult? To have a phase 3 with HER2 positive cholangiocarcinomas?
Yeah, it's difficult, but now there are 2 ongoing phase 3, one by AstraZeneca and one by Jazz with TDXD here, and the other one with the zanidatamab.
So if you see the Destiny Pan-Tumor 02 trial, so 41 biliary tract cancer patients were enrolled in that, of which 53% patients were IHC 3+. So that is very important, IHC 3+. But centrally confirmed rate was about 40%. Then most of these patients received prior HER2-based treatment. Not most of these patients, 17% of the patient. We see the objective response rate here. This is very interesting because IHC 3+ patients had 56% of them responding, and but obviously IHC 2+ patients, the response rate was not good. IHC 1+ also. So I think overall it was 22%. But what is more striking is in patients who are IHC 3+, half of them responded to TDXD in second line or third line. And if you see the median duration of response, that is about 8.6 months. Again, for IHC 3+ patients. So again, this is very important. And the take-home message here will be that for using, HER2 positive, the TDXD for HER2 positive patient, you have to do IHC and it should be 3+. Low positive patients may not respond, unlike in the data what we see in breast and all. So IHC 3+ is mandatory for using TDXD. If you see the PFS, so this is for the entire cohort. So for TDXD, for IHC 3+ patient, median overall survival is 21 months. This is for all tumors. But if you see the BTC cohort, again, it is very important because the median overall survival, remember that this is second line. median overall survival for IHC 3+ patients is 12.4 months. If you see the PFS, it is 7.4 months. But again, in second line, a drug giving a median overall survival of 12.4 months is amazing. I'll skip this, but safety summary, nowadays we are using more and more TDXT, so we get the heat of it once in a while. We do encounter pneumonitis. We have to keep a close watch on that. But other side effects are quite manageable, especially the myelosuppression part and the vomiting part with proper antiemetics. But you have to keep a close watch on the pneumonitis part. We see the pivotal studies of trastuzumab-based treatment for BTC. You can see there are multiple trials mentioned there. The TAP trial always, as we mentioned, stands out with the overall response rate of 80%. But the Destiny PanTumor02 trial shows that 56% of the patients respond to HER2-based treatment. So that's it. With that, I'll close this panel discussion. We'll move on to the next panel discussion. I would like to invite Dr. Arun Warrier to present the next panel discussion. Dr. Rimasa will be joining this panel also and share her valuable inputs. Dr. Nikhil, Dr. Jayashankar, and Dr. Unnikrishnan also will be joining for this panel discussion. This is on recent advances in the management of advanced HCC. Over to Dr. Warrier.
Thanks, Dr. Sanju, and thanks to AstraZeneca for this academic initiative. And it was a very good discussion still now. So we will just continue with the main thing which we are all dealing on at a regular basis. Although biliary tract cancers are not that common, so SCCs is a very common thing. All of us see new cases almost in our practice. The case load has gone up so high. So already the data has been reviewed by Dr. Rimasa, who is an expert in this field. So we are fortunate to have her, and we will definitely like to get her opinion, because there are many things which are still baffling us when we are dealing with HCCs. So just to adjust a case, one 60-year-old male with a history of chronic liver disease. The history shows, the imaging shows routine multifocal HCC with multifocal thrombus and along with bone mets. The lab elevations, the evaluation show mildly elevated bilirubin 2.1, AST/ALT again less than 5 times normal, alk-phos is elevated, and AFP is 8.8 itself. The CP class is A, and the patient is in good performance status also. So I think in this case, particularly so these are the questions provided by the team. So definitely, I'm sure that in this case there is no need for a biopsy, but just to get the discussions going. So Dr. Nikhil is there?
Yeah. Yes, sir.
Yeah, Nikhil. So generally we all avoid a biopsy, but can you remember any situations where you had done a biopsy and it was why you did that?
Yeah, most of the situations are probably where we do not have a very clear-cut radiological answer, or we have a borderline lesion that is somehow not correlating with the clinical diagnosis. I would definitely do a biopsy in the setting of a patient having a normal, the absence of chronic liver disease in the background. And again, as we mentioned, radiologically indeterminate lesions need to be biopsied. You might not have the classic washout that we see. So this would be the scenarios of doing. Of course, some certain subtypes like when you're suspecting fibrolamellar HCC, we can consider biopsy.
So Dr. Jayashankar, any scenarios where it made a difference for you?
Yeah. Actually, the scenario where I do a biopsy now is exactly what Dr. Nikhil has already pointed out.
Correct, yeah.
But previously, I used to do biopsy for all patients when foundation one was actually complementary with the Tecentriq. And in
Yeah.
such a scenario, I remember one patient who had actually failed to the first line atezolizumab. So after 4 cycles of atezolizumab, actually he progressed. And this Foundation 1 test report actually showed mutation in FGFR gene, and also some pointers towards resistance to immunotherapy. So for that patient, we had this discussion with their team, which also comes along with the foundation test, and they suggested using lenvatinib because of its FGFR inhibition property. And for that patient, I started lenvatinib, and that patient continues to be in very good partial response even after 3 years of starting lenvatinib, which is very unusual in HCC. So that is one case which I remember where biopsy made a big difference.
That's great, Dr. Jaishankar. And Dr. Unikrishnan is there. Today we have both biliary and HCC, both we are discussing. And nowadays, many cases we have this suspicion whether it is a mixture of tumors or not, isn't it? So, any views on that?
Yeah, so that radiologist as a key players in that actually, but when there is a doubt arises from their side, and also tumor markers, CA19 and AFP is both high like that. So in that case, even for a CLD patient, sometimes we may go for a biopsy, and we are seeing a lot of cholangiocarcinoma inside the cirrhotic liver. So in that case, definitely we'll do biopsy.
Professor Rimasa, what is your institutional guidelines? Which cases you go for a biopsy?
Yeah, we prefer to biopsy if there are no risks for the patients, because sometimes even if the radiological characteristics are typical, even if patients with liver cirrhosis, we identify patients with cholangio or patients with mixed hepatocholangio, and since now the treatment can change based on the histology, and also if the diagnosis is cholangio, then we do the molecular profiling. So we prefer to biopsy the patients. We don't biopsy some patients with liver cirrhosis with a clear radiological features if there are a high risk of bleeding for the patients. But if not, we are used to biopsy all the patients.
So, being one of the experts in the field, do you feel that if you do biopsy, more patients will know more about the biology and mutations and all those things, or do you feel that liquid biopsy has some role in such situations?
Now now only for research, because we don't have enough data to consider the liquid biopsy for diagnosis or for monitoring treatment.
Do you see
for
coming
research, yes.
Coming up in the future, liquid biopsy?
I hope so, because it's better for the patients. So there are some data showing for instance, the liquid biopsy after surgery, and showing a correlation with ctDNA, between ctDNA and relapse and prognosis. So I think now in terms of research, yes, and hopefully in the future in clinical practice.
And all of us have this issue of this mixed cholangio HCC picture. So, any thoughts on that? I mean, how do you break that jinx? Which to treat or what to call that? Yeah.
Oh, actually, now that we have the Cisgen Durva, we generally treat the mixed as cholangio, because if we declare that there's a mixed tumor, we cannot use durvalumab in combination with Cisgen. Or we can, but it's not reimbursed. So we declare that there's a cholangio, and we use cisplatin gemcitabine durvalumab. So we have Cisgen that is, and Cisgen Durva that is active for the cholangio. We have Durva that is also active as a single agent for HCC. So I think it's now the best treatment for the mixed.
As of now. Correct. So this is, I think, very broad question. So first line HCC, what is the current practice? All the options are there. So we'll start with Nikhil, and definitely finance is not an issue. We are in an academic setting now, so everything is there to give. So Nikhil, how will you?
I think with this particular set of data that we have been reviewing, and what Professor Rimasa has been pointing out, we are comfortable with the immuno-based treatment when we don't have any, I'm comfortable both in giving atezolizumab, bevacizumab, probably I may choose durvalumab, tremelimumab in our population because there seems to be a subset. I know it's a subset analysis and I'm extrapolating a little more than it is actually powered for, but there seems to be a beneficial in this particular subset compared to atezolizumab. Even though most of our patients fall in this etiology rather than infective or we don't have much of infective etiology. So I think Durva-Tremi, both STRIDE and atezolizumab would be my choice. I may decide it based on the presence of varus. Etiology would be a factor for me in this scenario. I may prefer Durva-Tremi in NASH background of
So which is
NAFLD.
the one which we commonly see also, isn't it? And I think
Yes.
Jayashankar also will have the reflect the same things or any.
Yeah, I also have the same opinion. But have been using atezolizumab more often, mainly because of our experience with using that regimen. And I usually reserve patients for STRIDE mainly if they have some contraindication to anti-VEGF molecules. So otherwise, for most patients, like atezolizumab.
Yeah, Unikrishan?
Same opinion.
Same opinion. Any okay. And this upcoming EP-Nivo, are you really excited about that? Only EP-Nivo or
it has actually the best response rate,
Response
median OS, compared to when it comes only to efficiency numbers. I think Nivo EP has the best response rate of around 33%, median OS of 23 months. So looking at the efficiency in points, it looks promising.
At IP-Nivo, that the comparator, the TK was also having very prolonged survival, I think.
20 months.
20 months like that.
yeah, and but again, are we not missing on the anti-angiogenic here? Because it's easy, anti-angiogenic has been there from the sorafenib time. We know it's an important thing. Suddenly, why no anti-angiogenic? So, do you feel that is a issue?
Definitely,
Well,
anti-angiogenic
yeah.
has some role in this setting. I think Professor Rimasa
I
can
think,
answer
for-
better.
Yeah, Professor Rimasa, maybe your thoughts on this or the.
So I think that, of course, we have data with lenvatinib that we didn't have before, but I think that immunotherapy combinations should be the first choice. If patients, for any reasons, cannot not receive immunotherapy or don't want to receive IV drugs, for instance, lenvatinib is now a good choice because it's the 20 months overall survival is something that we cannot disregard. And regarding atezolizumab or durvalumab, I think that it's really difficult to choose between the two. I think that there are, in terms of efficacy, there is a difference. So we have a higher response rate with atezolizumab. We have long-term survival with the STRIDE that we don't have with atezolizumab. Or actually, we don't know, but we do not have the data. So for patients with metastatic disease where the objective response is not particularly relevant, at least to me, I think the STRIDE, I use the STRIDE in most of the patients. For patients with liver-limited disease where I may aim to local regional therapy or to surgery or even transplant, maybe atezolizumab is the best choice. And I don't have a great a large experience with EP-Nivo. I used in the trial, but not in clinical practice because, as I said, it's not reimbursed. The efficacy data are really impressive, but I will be happy to understand better what happens in the first months of treatment because it's difficult to explain to the patients that they can have a very long survival if they don't die during the first months. I would like to understand better what happens in the first months of the course.
So again, particularly means a lot of we are like we are not specialists like what you do. All of us treat many solid tumors. So we treat lung cancers, we treat kidney cancers, liver cancers, all of that's what the panel today is. So I think amongst the panelists also, for them, this EP-Nivo is a familiar regimen. Atezolizumab for many years, we are all familiar for the many years now. So Tremi Durva, one of the good thing is that we can avoid the problems of atezolizumab, which is a major issue in our population. So that's the thing. practical. So again, I think this has been reviewed well, so I won't go into the details of that. So Imbrave, we know, and Himalaya has come now, and Checkmate again seems to be, the survival seems to be different, and but there are some fallacies like Professor Remasa was pointing out, and I think pembrolizumab is not available in India, so we won't go there. So these three are the practical recombinations which are there for us now. So Imbrave, so Dr. Nikhil, so are we really able to stick to these eligibility criteria when we are choosing these regimens for our patients?
I think we have a publication and data. Us, Jay Shankar, and me together, our real world experience with Atezolbev. And what is striking compared to the Iambrave is that we do have quite a good bit of, B7 patients in this group, and few, maybe more than B7 patients also. So most of the time, we're not able to stick to it. You have the very good, healthy B7. Of course, the people who have done better are the ones who are all Child-Pugh A, and we're able to get them within the trial criteria. They're the ones whom we're also able to give, the ones without varus, whom we are able to give a higher doses of bevacizumab. Lot of time there's the issue. Lot of the issues are with the bleeding, etc. So we have a lot of dose adjustments that happen, and we do take quite a bit of B7 patients in our practice. Most of them are diagnosed when they are B7 with both HCC and CLD.
Yeah. Dr. Jayashankar, you work in a very busy GA gastro hospital where I am sure that with a close follow-up of CLDs, you may be picking up more of CPAs nowadays, isn't it?
Yeah, actually, I just what concurring to what Nikhil said, I was just reviewing our institutional data on the patients who have received Atezolbev, and it is true that actually once it is B7, there is definitely a drop in benefit. So the patients who did best are actually the child A patients, and even though we do include many B7 patients, it is the benefit is very marginal. And also, actually, one trend we have started using is we have started combining more patients with local therapy with systemic therapy. So we have many more and more number of patients where local therapy is being combined with immunotherapy.
Yeah. Punikrishna, any thoughts from Amala?
Yeah, we actually we didn't get the data analysis so far. We are taking the data, but whatever available is the same whatever we discussed, because that eligibility, the A Child-Pugh A is the getting the maximum, and B7 and even some B8 patients, but they are not faring well. Actually, they are early deterioration, and the bevacizumab, the full dose 50 mg per kg. It is quite a difficult thing to give.
Yeah. So again, because all of us work in oncology centers, this VP4 like that stratification and all, I don't think we are really able to practically do that, isn't it? Yeah. No, any Jayashankar, maybe Amrita.
Yeah.
How is it? Yeah, Jayashankar.
Yeah, BP4 patients for systemic therapy, we are not leaving out BP4 patients. But when it comes to this comes to discussion mainly when it comes to local therapies.
Fine.
Comes on the intervention, the tumor boards for the BP4, not for.
Yeah. So Nivo-IP, I think we will skip that for today. Yeah. So Himalaya, again, they're telling there is no need for upper G-scopy, but I think most of us do that by practice. Maybe it will help in understanding what is the real health, what is the situation with the patient also. So again, just a query whether if you're thinking of Himalaya, will you want to do an upper G endoscopy, or you will without that you will proceed? Nirshant. Tomorrow you're going to start Himalaya.
For this Himalaya, I will not insist for if there is no patient is having no much bleeding symptoms or anemia like that. I can avoid actually mandatory upper G-scopy, I think.
Okay, right. Yes, so I think the side effect part has already been told, and the data I'm not going again, because that has already been discussed. So I think all of us have used Stride for now.
Yes.
Jaishankar, Nikhil, and
Probably because it's a newer thing in the reimbursable sector, where I depend more on reimbursement rather than patients paying out of their private insurance or from their own pocket. So like, the government sector. So it has been recently only come. Handful of patients, reasonable. Definitely the tolerance is better. Like this, I'm comparing the tolerance with the Nivo IP. I'm probably I'm comparing the toxicities of a CTLA-4 anti-CTLA-4 agent, and definitely the single dose Tremi seems to be okay. I've not had major issues in that. 4 patients we have totally administered to. I have administered to.
Professor Rimasa, again, one query, because for us, the tremelimumab is a new molecule for us. Atezobev and Durva, we all know. So do you think that anything particularly we have to be cautious when giving this drug, tremelimumab?
Yeah, I think that the good point is the single dose, but the single dose is 4 times the regular dose, so 300 milligrams instead of 75. So I think for the first cycle, for instance, monitoring the patients, checking for the liver function test, I prefer to see the patients in between and not say, okay, let's schedule the next visit in 28 days for the second cycles, because you can see increase in transaminases or other adverse events related to tremelimumab. Overall, it's very well tolerated, as shown in the trial. But let's say the first cycle is the one where we should be more careful, and I prefer to monitor a little bit stricter the patients.
So again, I had a patient whom we gave the first Stride, and now it is the 3rd week. Already the bilirubin has doubled from 1.5 to 3. The enzymes have gone up to 300. So I hope already because tremelimumab, and how long will it take to settle such patients? It was a CPA patient only otherwise.
Yeah. So when there is also increase in bilirubin, of course, if there is no disease progression, we prefer to administer steroids and then monitor the liver function test, and then taper the steroids before stopping them. But for instance, in the case I presented, it took 2 months to. Yes, because the first cycle, then at the time of the second, we still had the grade 3. So yes, more or less 2 months. And then we didn't observe any further liver toxicity administering the following cycles with the durvalumab only.
So again, practically what percentage, approximately 1 in 5 will get this, or is there any numbers which you are seeing? Practically, I'm asking, that's all.
Practically, I just asked to see the patients, let's say after 1 week or 2 weeks with the liver function test, and then if it depends, if they are in good clinical conditions, they can come to the clinic, have the liver test check, maybe an ultrasound if feasible. If they are not in good clinical conditions, so sometimes you have to admit them and monitor as an inpatient.
So any experience from other panelists about this first cycle problems with this Stride? Because most of us are in that initial few months of therapy, isn't it? Other panelists here? Dr. Sanju, experience?
I have not encountered. I have given only for one patient. And that patient responded well. So this is a new thing for me, but a very important thing to keep in mind when we give this drug.
So this is again 5-year OS, and so now we have one more thing like ALB, which is coming up. So I think a lot of scores when they come from the hepatologists, especially a lot of scores, including MELD-NA. So we had to read about our scores they are using. Now one new thing has come, ALB. So what is your opinion about ALB, Dr. Nikhil? ALB score, do you really look into that?
That's the right thing. One of our, I think, PhD students was looking into the ALB score and prognostication. I think the poster was put up recently. I am not, and at my this thing, I'm not doing it. ALB is reasonably easy to replicate, unlike the more complicated MELD. But it's easy for us, clinicians to child's view is much more easier to do, and it's reasonable. It still works. It is effective. I don't find any reason to change it when it comes to assessing liver function from our oncology.
Opinions from Jaishankar and Unnikrishna about the ALB, the new kid on the block.
ALB actually, I am not using ALB, but actually ALB is said to be a better prognostic factor than Child-Pugh, and also it has actually, even within the same Child-Pugh category, it will differentiate patients into different prognostic strata even within the same Child-Pugh. So we actually, ALB is more often used in our hospital, mainly by the surgeons and the local treatment guys to differentiate patients with a better ALB will be taken up for reception, or the other way around. Patients with a worse
Actually,
ALB
I
will not be
was
spared.
checking that when you look the ALB score, the survival is some ranging from 8.5 to 45 months. So I don't know that whether that is a grade, I think 2 or something, the ALB score gives such a huge, even if you look at all the survivals, it is like a big range is there. So as a medical oncologist, we are not used to that. Maybe it's they are doing for the grade and there is some code. That's what I may not be to think about survival. So Professor Rimasa, your comments about this ALB and how useful has it been for you?
I agree with all the comments. So in clinical trials, it's clear that ALB better stratifies patients in terms of prognosis, and also in some way in terms of response or benefit from treatment, especially for probably the Child-Pugh A6 that is better stratified. But in clinical practice, and I most frequently use the Child-Pugh, I have to say.
Yeah, I think the Himalaya people are because there's a drastic changes there. If you look at ALB grade 1, the survival is 23 months, while if you look at ALB grade 2 to 3, it is 11.3. So, so that means it is really important if you are going for stride.
Yeah.
We can look at this and then choose. So, Nikrishan, do you feel this is an important factor for you to choose?
Sir, for sorafenib also,
is doing well also.
For sorafenib also, that difference is huge.
Yeah, huge.
0.72 versus 19.2.
Correct. So that they are picking out the good people. That's what. Yeah.
Yeah, the ALB grade. I think when recently only I gone through this ALB grade, and as we already discussed, it is having a lot of implications in the survival. Even though the treatment recommendations are not based, but I think we can have a good prediction of the survival based on ALB, I think. And that selection of this Himalaya, I think that lower ALB, higher ALB, having a fairly good response, we have to. You can have a choice based on ALB in the future.
So again, if somebody finances an issue, we can counsel based on this. The ALB is good, we can tell that you respond better or vice versa. So I think subgroup has already been told, like fortunately in our sittings, viral associated is so rare. And Nikhil, do you remember that I think we had very few numbers in the viral etiology in our data set?
Less than 20%, less than, in fact, somewhere around 10 or 11%. That itself we felt very high and we rechecked the value. Most of it was steatohepatitis.
Yeah, national rate. Yeah. So anyway, so this is very clear here. So based on etiology, I think this has been a question we have answered a lot. So I think the answer is very clear for us. So etiology may not matter much. I think Atezolizumab, one of the main things which you are telling is that non-viral disease, it is not good, but then some other data came in. So that has been a big debate. So Professor Rimasa, your comments on this etiology?
Yeah, So in my opinion is that based on the data that we have now, there is no reason to select based on etiology. If you look at the forest plot, for instance, the forest plot that is shown now for the IMbrave, it's clear that the patients with non-viral HCC seem not to benefit. But then there is a subsequent exploratory analysis, reanalyzing the data, only in the Atezobev arm, and patients had the same progression-free survival and the same overall survival regardless of etiology with Atezobev. And also for STRIDE, here it seems that patients with HCV did not benefit or benefited less, but there were some imbalances, and then after the adjusting for imbalances, there was a benefit also for HCV. If it's really clear that the HBV patients with the HBV benefit more from immunotherapy, but this does not mean that patients with other etiology shouldn't be treated with immunotherapy.
So I think there is means any infections, infectious causing things, immunotherapy should work better. That's what we have seen in everywhere. But this HCV is a little unusual. So maybe it is something about the data or something that otherwise we won't expect this. And that NASH is also doing well with the STRIDE regimen. What can be the reason for that? Even the NASH we thought may not be that immunogenic, but that is also doing well. Any reasons has been cited for that? Or it's
But
just
actually, I don't know if it's not immunogenic. There is a continuous stimulus in the liver, so there also could be activating immune tumor microenvironment. The most important data suggesting that the HCC, the NASH HCC, let's say, are the data published in Nature some years ago, and the clear lack of benefit was in mice. And the small cohort of patients published in the Nature paper, and some patients are from our institute, are patients retrospectively collected to address reviewers' comments. So, I mean, okay, those patients seem not to respond to immunotherapy, but that it was a retrospective analysis. And here, after reanalyzing the data for both IMbrave 150 and Himalaya, the benefit of the immunotherapy combinations was shown also in non-viral HCC. So probably we don't understand very well enough the reason, but as I said, I wouldn't have. I don't think patients should be. Yeah, exactly. Yeah.
So CTP score again, most of us may go for B7 and practically even lower down also. So any comments from the panels, because we all know it's for CTPA. Unikrishnan, yeah.
Childhood B, as which we discussed B7 till B7 we are treating but I think this Himalaya and all only class A is included, I think, but
So
but
I think we'll skip that because I think practically most of us.
Yeah.
So this is one more case, and I think local regional treatment. Jaishankar was having some comments on that. So this is about that TACE. So I think we are just running out of time. So just we'll have a few comments from the audience. So Jaishankar, about how you blend both together, local and systemic therapy in your tumor board.
Yeah, actually, that overall trend is that we blend local and systemic therapy for more and more patients. Like if a patient is having a disease which can be addressed with TACE, but suppose the patient has features suggestive of a very aggressive disease, like very hazy margins, multiple satellite lesions, AFP not reaching the baseline after the local treatment. In such, we don't wait. We start the systemic therapy because it's just a matter of time before a new lesion appears or the lesion reappears in the rim. And also, if a patient has got a portal vein thrombus, obviously not an extensive portal vein thrombus, but a portal vein thrombus which can be addressed with SBRT. Definitely, SBRT will be combined. And this trend actually started with the publishing of that lenvatinib TASTE trial. And so I'm just saying that it is highly personalized. But the trend is like more and more patients receiving a
generally
planned.
you will be going for sorafenib, lenvatinib, or immuno. You will be thinking at that point.
Started with using lenvatinib because of the because their lenvatinib TASTE trial came first, but actually now stopped using lenvatinib and shifted to immunotherapy. And actually, we are also planning a planned like a phase 2 trial combining SBRT with atezolizumab.
Oh, that's great. Nikhil, how does your MDT goes about local?
I think this SBRT atezolizumab with some Tata and all that, I think it's been planned. I think it's a reasonably large trial also phase 2. I think, is this the one with the Tata, some fundings from there also, Jaishankar?
Yes, Nikhil.
Yeah, so same. So it's a interesting. We are actually I mean, I've been using a lot of TACE and lenvatinib, and even before the positive data, select patients, some TKs and TACE we have used in combination in the past also. They do usually the patients probably we are selecting for an local regional therapy along with the systemic therapy because of some good fact. They do slightly more better than the patients whom it's a basically patient selection bias, slightly better biology because we have some treatable lesions. What is more interesting or what is the change in practice is lot now SBRT is being incorporated much more. We have those patients with the portal vein and some treatable lesions are large lesions, symptomatic treatable lesions are also radiated. Give systemic therapy, immunotherapy. Probably they do reasonably well. I mean, if they respond to systemic therapy and the radiation both together, they do well. Maybe the new antigens, I don't know what is the thing.
Yeah, I have a few patients where I combined SBRT with even that lenvatinib, and with immunotherapy, I don't have patients combined with local therapy. So, but the lenvatinib case, that SBRT patients who we had is going well actually. So I think it is purely patient-based, individual-based approach. And yeah.
So, Professor Rimasa, any one doubt was that when we use these therapies,
No, I agree. Actually,
before they
we don't
become really
use.
metastatic, it alter the biology. Yeah.
No. I have the same comments as the other panelists. So we don't use the combination TACE plus immunotherapy as in EMERALD-1 or LIP-012 because it's not yet approved in Italy. But combining, for instance, SBRT on tumor thrombus or combining some kind of local regional plus systemic to avoid disease progression in the liver when there is a lesion in specific sites that we use. We discussed the MDT meetings and then we go for the combo.
But once we use that, means the whole means will it change the biology of the tumor? And if we give lenvatinib with TACE, then further can we really give immuno later? So difficult scenarios, isn't it? We don't have answers for that, I believe.
Yeah, we don't have answers. Yeah, but we have some data. So I mean, we generally start with immunotherapy, but if you start with lenvatinib, yes, of course you can combine lenvatinib plus TACE, but then you don't have data of immunotherapy after lenvatinib.
So yeah, these are all tough cases, and I don't think we have it's all individualized. So all of us are aware. I think we are running out of time. So I think we have discussed all these issues, and we are aware of the improvement in PFS and the survival benefit which comes, and even len plus pembro also, and survival curves are here. So this I think already we have discussed this. So finally, the last is that it is a very prevalent thing, and there is definitely an unmet need. And I don't think there will ever be protocols because it is a very heterogeneous tumor, and you have to individualize the treatment, give local therapy as far as possible, try to combine, and to try to initiate the systemic therapies early. So I think that is where we will end. Thank you, and back to Dr. Sanju.
Thank you, Dr. Arun. Thank you, Dr. Rimasa, for joining us today. These topics are very dry topics and, very difficult to understand also, but we learned a lot today from you. And thank you so much, dear panelists, also the moderators. So thank you so much for joining us today. I think tomorrow onwards, we'll be in a much better position to take a better decision for our dear patients. Thank you so much. Signing off, and good night to all.
Thank you.
Thank you.
Yeah. So thank you, Dr. Sanju, and for all the moderators and panelists who have joined today, especially Dr. Rimasa, who have patiently answered all of our questions. So thank you. Good night, everyone.
Bye-bye.
Yeah.
Bye-bye. Thank you.
Yeah.